A good example of it is the skin that lines inside of our nose, for example, and our throat. So when they've got otitis externa with inflammation, there's limited space in the ear canal. The average ear canal width, it's a range between, say, 5 and 7 millimeters in width. The height between 0.8 and 1 millimeters. I would say in this particular patient, because the ear is swollen and inflamed, the width is probably, and I'm using a fine end suction probe here, so the diameter of this is, I think, 1.28 mil. The normal size Zollner suction probe, which is what I used at the beginning, is 2.1 mil, and that just about fitted. So I would say the width of this patient's lateral part of the ear canal, the entrance where it's most inflamed, it's probably about 3 mil. And then the height is probably about 0.7. So it's just not the instrument in the ear, we've also got the endoscope. So the iClearScope, the diameter is 2.7 mil, and I'm using the fine end at the moment, so that's 1.28 mil. So if you add that up, it's about 3.38 mil, I believe. So we've got very, very limited space in the ear. So we're having to use the endoscope to stretch the ear open. That's the secret. And that's why this procedure is difficult, because it's a very technical procedure. You have to get the endoscope in the right position. You have to stretch the ear by the correct degree. I have to be positioned in a certain angle. The patient's head has to be tilted in a certain angle. And we're using the tip of the side of the endoscope actually to not only stretch the ear open, but to keep it open as well. So it's almost like a doorstop. And then to insert the instrument, we're having to use the instrument at the same time simultaneously to stretch another part of the ear. And this is all done without obviously making contact with the ear canal as we're entering with the instrument, so that would be painful. And then because it's the left ear and I'm right-handed, your hands inadvertently kind of almost cross over if you don't have the right technique. So that's the first technical challenge. It's the ear anatomy and the limited working space. The second challenge is the consistency of this debris and skin. You can see it's wet, macerated, damp, mushy. It's lined the canal wall. I got the blockage, the majority of the blockage off the eardrum already. That's the eardrum there. We can see the posterior part. But you've got all this sticky debris. It's the hardest stuff to remove, because initially when I was peeling away the skin near the entrance, that was quite dry and it just came away in long sheets of skin, slithers. This is all mush. It's like mashed potato. And we're literally having to take this off the eardrum and canal wall, but without making contact with the canal wall in particular, because that would be very, very uncomfortable. So if you're new to the channel, or you don't often listen to the narration, I always try to describe the ear anatomy in terms of the outer third of the ear canal, which is made up of cartilage and a thick layer of skin, which is about 1 millimeter in thickness, and the inner 2/3 of the ear canal, which is made of bone and which is lined by an extremely wafer-thin layer of skin, about 0.1 millimeters in thickness. And that makes the inner 2/3 of the ear canal very, very sensitive. What I'm doing here on the outside part of the ear canal, you can see I was putting pressure on the canal. I couldn't do that on the bony part. That would just be so uncomfortable for the patient. So I'm actually having to glide across the canal wall to separate this debris and wax from the canal without making contact.